Okay, so I think we'll start. So welcome, as I said, good morning or afternoon or evening to all of you, and welcome to this week's webinar on palliative care and COVID-19, holistic care of children and symptom control. This webinar is being recorded and will be available shortly after completion. So my name is Professor Julia Downing. I am the Chief Executive of the International Children's Palliative Care Network, and I am delighted to be moderating this session today. So this session is the fourth in a series of 10 in a project on palliative care and COVID-19, which has been developed jointly by the International Children's Palliative Care Network, the International Association for Hospice and Palliative Care, Palliative Care in Humanitarian Aid Situations and Emergencies, and the Worldwide Hospice and Palliative Care Alliance. So the objectives of this series is to provide globally relevant information and guidance to civil society, UN organisations, policymakers, administrators, and healthcare providers on palliative care in the context of the COVID-19 pandemic. So these webinars are accompanied by briefing notes written by experts from around the world. And these briefing notes are available on the globalpalliativecare.org website, as well as on our different organisational websites. And we are very grateful to the contributors of this series, and would like to thank today's presenters for accepting our invitation to participate in this collaborative project. So this webinar will feature 3 15-minute presentations, followed by some reflections from Sharon Thompson, who is a mother from Ireland who has lived experience of palliative care, and she will share her reflections on the topic. Then after that, we will have some questions and answers. So you can submit your questions through the chat box, and we have Shelley and Kate from the Worldwide Hospice and Palliative Care Alliance, who will be condensing the questions and then reading them to our speakers. So within the series of briefing notes, we've developed 4 around children, and we will be looking at those today. We've had support from a range of experts from around the world in developing these briefing notes. And I think it has been an interesting experience, as we have learnt from each other during the process, sharing how we do things in different places, discussing the differences and the resources we have available, and also our current understanding of the impact of COVID-19 on children, and in particular children with palliative care needs. However, despite the differences and the national responses and differences in resources, we have similar challenges, and many of the principles behind the care that we provide are similar, and the concerns that we are hearing from parents around the world resonate with each of us. So let's move swiftly on to our first presentation. So Stephen, if you could put the next slide up, please. Our first speaker is Dr. Ana Losada, who is a paediatric oncologist working within the Paediatric Palliative Care Hospital team at the Portuguese Institute of Oncology, Lisbon Centre. She's leading paediatric palliative care activities within Portugal, and she is a great advocate for paediatric palliative care. And she's going to be speaking about caring for children with underlying serious health conditions during this COVID-19 pandemic. So over to you, Anna.
Thank you. Hi, everyone. And I'm honored to be presenting this first briefing note about caring for children with underlying serious health conditions during the COVID-19 pandemic. As Julia said, it's a group work, and I will just be presenting the main ideas about the briefing note. Can you pass the next slide, please? So, okay, so this is the page 1 of the briefing note. You can download the briefing notes at the website as well, and you can read through them. Hopefully you did that before, or you'll do that after the webinar. Next. So the first idea is that in the past 2 months, we've all been aiming our weapons at COVID-19, at this terrible virus. But the truth is that other illnesses, other conditions are still out there, and our patients, especially our children with palliative care needs, are still out there and still need us. Next. So why are we so concerned about COVID-19 and children with serious healthcare conditions? We of course know that children seem to be less affected in numbers than adults, but also in severity. So most children seem to be asymptomatic or only have mild symptoms. And the number of pediatric deaths has been so far very, very small. But we also know that people, and especially children with underlying serious conditions, may have a more serious disease, leading maybe to an admission to an intensive care unit and life risk. Next. So, what do we know? We know that this virus is very, very, very infectious, highly infectious. So, healthcare professionals need to be protected when caring for people with suspected or positive coronavirus infection. And we should also be protecting people who are at risk, like children with palliative care needs, with, as we said before, underlying serious conditions. We must also remind us that their carers should also be looked at as population at risk, because they are in close contact with our children with palliative care needs. Next slide. We also know that these children with palliative care needs and their families most often rely on an extensive range of support services and at-home services. And unfortunately, the last 2 months have really been a source of major changes in society and in the workforce. And also there is a fear of contamination, both from the side of healthcare workers and from the side of families. So we are all afraid of each other, even crossing in the corridors or on the street. So this may lead to major changes in the supportive care that is given to these children and families, and especially at home. For instance, in Portugal, and I'm sure the same is true in other countries, home care teams have been asking for COVID-19 tests for children and for their main carers. Next slide. And we also know that it's true that these children with palliative care needs should have prepared advanced care directives well before the end of life, ideally at the beginning of the disease trajectory. So this is probably a time to revisit this advice. Next. So what should we do? And we have divided this into recommendations for healthcare providers and then for families. So as healthcare providers, we must recognize that families are going through an additional stress on top of everything that's always been going on with their child. And but it's also more stressful for us, ourselves. So we also have, I believe we have the duty to also look at ourselves and take better care of ourselves. If possible, we should substitute regular appointments with virtual care. This is probably easier said than done. For patients who are already our patients, when we have developed a trusting relationship with the families, it's probably easier, but for new patients, it might not be so easy. We may also consider increasing intervals between appointments or between treatments if it is safe, if we don't believe that this is going to have a negative impact in the condition. Also, if we believe it possible and not having a negative impact, we may consider substituting at least some of the treatments, of the interventions for oral administration instead of a parental administration, meaning intravenous or intramuscular. So probably allowing the child and family to stay at home longer and not have to interact with the healthcare system. We should also promote the elaboration or reviewing the life-affirming advanced care plans that are maybe in place for these children. If they don't have one, maybe now it's the time to do one. We should also avoid separating children from carers. And I know that in many places, visits are not allowed now in healthcare institutions, and the carers are only limited to one. But it's really important for children to still have at least one carer, one parent with them if they need to be away from home. And we should also share our experience, the way we are dealing with this problem with others, with our colleagues and with the families, because we're all learning from each other. It's a new reality for everyone. Next slide. And families, what can they do? Well, they can make sure that they are keeping regular contact with providers, be it through virtual medicine or social media or text messaging, whatever works for them. They should make sure that they have enough supplies and enough medicine at home to last at least for 1 month, if not longer. Families should also prepare for the illness or sudden absence of the main carer, and they should appoint and prepare a substitute carer, because it's not in 24 hours or even less than that you can prepare someone to care for a child with palliative care needs. And families should also prepare for SARS-CoV-2 testing if the need arises. So they should know where to go, who is going to pay for the test, how it needs to be done, what arrangements must be done. Next. So this is it. This was the briefing note about caring for children with serious health conditions. And remember, we can all be heroes, even at home, not only in the healthcare institutions. Wash your hands, stay safe. Thank you.
Thank you very much, Anna. And this is certainly one of the areas that as ICPCN we have had quite a lot of communication from families around how do we make sure that their children are kept safe but still get the care that they need. Can I just check, there's been a comment in the chat that some people can't hear. So hopefully everybody is able to hear us okay. So as we said earlier, we'll be taking questions after all of our presenters have spoken. So I've now,
sorry, just a suggestion for attendees that can't hear. You should go up to the Zoom icon and go to preferences and go to audio and check your settings and make sure you've got a microphone attached to your computer. Thanks.
Okay, so hopefully you'll all be able to hear. So as I said, I'd like to welcome our next speaker, who is Dr. Sat Jassal from Rainbow's Hospice for Children and Young Adults in Loughborough in the UK. He's also been the lead on the Association of Paediatric Palliative Medicine Master Formulary. And I know that many of us around the world use that master formulary, and it's been translated into various different languages. So Sat is going to speak to us around symptom control at the end of life in children with COVID-19. So thank you very much, Sat.
Thank you. Next slide. Firstly, thank you, Julia, for inviting me to participate in this project, and thank you, Stephen, for organising the actual presentation today. I'd like to highlight the briefing notes to everybody, which you may have read already, or I'd encourage you to read at the end of this briefing. The main thing I'd like to point out is that this is not the work of 1 or 2 people, but actually an international piece of work, and the briefing notes are meant to cover different parts of the world. And I thank all the people who participated in this. Next slide, please. So let's talk about a few, let's talk about some principles in terms of symptom management. Now, the first thing that has to be said is that the current figures are showing very few children who have died directly from COVID-19. This is a relative sort of thing in comparison to the number of adults who have died. If you want to manage the symptoms, then the key thing is to understand the natural history and physiology of the actual infection. It allows you to predict and pre-plan the symptoms. And the current sort of feeling that this is a respiratory condition is not really being borne out by the research papers that are coming through right now. Essentially, although COVID-19 is affecting lungs, we also know that it affects the heart, kidneys, nerves, muscles, GI tract, brain. So this is a sort of a multi-system illness. So when you're looking, you really do have to think beyond just respiratory symptoms. Although our focus is primarily on respiratory symptoms, this is a multi-organ type condition. Now, a little bit of controversy, a little bit of unknown here. There may be hidden deaths out there because COVID-19 appears to have a major issue with regards to a kind of inflammatory syndrome. And here in the UK, we call this pediatric multi-system inflammatory syndrome, temporarily associated with COVID-19. So we don't know if it's COVID-19, but all of a sudden we're picking up a lot of inflammatory type conditions, very similar to Kawasaki's disease, although Kawasaki's classically is for under 5s, but this is affecting all age groups. The figures from a recent webinar where participants were asked to submit their own figures for a number of cases reveals quite a few cases both in the UK and the US, Canada. So certainly quite a few countries are picking up these sort of cases. And there seems to be a preponderance of children who have become seriously ill with this inflammatory disorder. So keep your eyes and ears open, remembering primarily that the type of children we look after are high risk within all of these things. And remembering that the inflammatory disorder is affecting multi-systems, not just lungs. Now, one of the other key things with symptom management is COVID is not the only fruit out there. Our kids have been getting infections from all sorts of other bugs and getting other complications such as heart failure, etc. So be aware of COVID, but don't think that everything is COVID. Don't jump to that conclusion. By all means, get the child tested, but keep your normal medical and nursing hat on so you are picking up other illnesses. So not all symptoms are due to COVID. And COVID does have some odd types of presentation, including diarrhea and vomiting, and also this sort of loss of sense of smell, loss of taste, which seems to be quite a common symptom. Next slide, please. The presence of parents, I think we have already sort of mentioned. The findings within the UK appear to be that patients seem to tolerate and desaturate. They tolerate low levels of their blood oxygen. And although in the past there was a rush to put people on ventilators, that seems to be, there seems to be a consensus of looking at the individual patient and looking to see how will they cope before rushing onto ventilation. Your prognosis in the adult world after being put on a ventilator is actually remarkably poor. The other thing I'd like to emphasize as a matter of principle is that your palliative care team are more likely to die of COVID-19 than the child in front of you. And essentially, you're of no use if either you get COVID-19 or you have members of your team dying. We're a very small group of specialists, and any loss is a major loss. So use the correct PPE. I know that Anna said about heroes. I don't want heroes. I want PPE on, please. Okay? You get no brownie points for dying out there. Now, I'm going to focus primarily on the pharmacological sort of approaches because that's my specialist interest, but I would strongly commend you all to look at the non-pharmacological approaches because these are very, very helpful, particularly if you are struggling with resources out there. Next slide, please. So let's start with simple pain. Now, with pain, go down the route initially of paracetamol. There is some controversy about using non-steroidal anti-inflammatory drugs such as ibuprofen. At this stage, don't rush to use ibuprofen. Try and stick to the paracetamol if you can. Above the paracetamol, then go to opioids. And morphine is our opioid of choice here in the UK, but I fully appreciate that in other countries, you may not have that available. Think opioid, don't think morphine. So there are other types of opioids out there that you may be able to use. And tramadol is a remarkably good opioid if used correctly and comes in various formulations that can be very helpful. Also think about the routes that you can use some of these opioids in, and think you can use buccal types of medications, but remember morphine does not work buccally. Diamorphine, fentanyl, use those. Do not use morphine buccally. Next slide, please. Now, for actual dyspnea, shortness of breath, take your dose that you would have for morphine and halve it and use that dose. Now, it will calm the child down. It will help their breathing. It's not just the opioid effect of making you feel good. There are other effects. Pulmonary artery pressure decreases. It helps with the breathing. Consider the benzodiazepine groups. Midazolam and lorazepam in small dosages can be really helpful for shortness of breath. But remember that the benzodiazepines are best for anxiety type symptoms. But if you have agitation and distress, you might need to look at using the levomepromazine type medications. They're better. Big controversy about using oral steroids because they can make things worse. And my advice to you with oral steroids is to approach carefully and only use if you have to. Please don't use fans as we would normally recommend because of the risk of spreading the COVID around the room and increasing the risks to the children. And there's some very interesting work in the adult world about positioning and the benefits of using correct positioning. And I'd commend to you your physiotherapist to help you with positioning of the children in terms of helping them breathe in these situations. Next slide, please. In terms of cough suppression, you can use opioids, but be aware that the use of codeine is not something we'd recommend. If you're going to use cough suppressants, then you can use morphine, but the dose I'd recommend there is 1/4 to 1/2 of the pain dose, 1/4 to 1/2. And that will act as a good cough suppressant. If you think the child's got a reactive airways problem, consider using inhalers and nebulizers such as salbutamol and ipratropium. However, be aware that once you use a nebulizer, you're now aerosol generating into that room. So I would avoid it if you can and only use it as if you absolutely have to. Okay, there are ways of trying to get inhalers working, the coffee cup technique, without having to go down the route of using nebulizers. We've already mentioned the issue around oral steroids, and be aware that cough assist will also generate large amounts of aerosol. So we are being tied in terms of some of the things that we can use here. Next slide, please. As far as fever is concerned, the same principles that we've already discussed, paracetamol avoiding ibuprofen, but remember with fever, Don't race to bring temperature down. A little bit of a temperature doesn't do any harm. It's just a high temperatures you're watching out for. And fluids are far more important than rushing around trying to get fevers down under control. And once again, try not to spread the bug around too much by using fans. Next slide, please. For the delirium, for the agitation that you'll see, my first line treatment tends to be haloperidol. It works really effectively. It helps with the anxiety as well as the confusion. I also would recommend levomepromazine to you. Again, highly effective, and we can give both of these drugs in different routes. A lot of this depends on what you have available in your part of the world in terms of what you can use. Next slide, please. So the key is, where do you get your resources from? I've listed the ICPCN website, the APPM website, and Together for Short Lives website. There's a lot of good information there. The Pediatric Palliative Care Master Formulary will have all your drug dosages in. It is a free download from these sites. It's a free download. So, and you'll get it as a PDF. So I would commend that to you. And there are some very good other websites, particularly within the UK. The BMJ website, which is free, has a lot of up-to-date information. And the Royal College of Paediatrics and Child Health also has a free section with all the latest guidance. Thank you very much for listening to me.
Thank you very much, Sat, and thank you for your help and for all of those people involved in developing this briefing note. I think this was one of the challenging ones because we use different medications, we have different medications available in different places, and we wanted this to be as practical and useful as possible. So hopefully we've come out with the right balance within that briefing note. So thank you again, Sat and the team, for working on that. We've very much just been looking with Sat at sort of the pharmacological management, and very important in the COVID era, and possibly because of the numbers of children who actually get COVID, possibly more important in some ways, is actually the psychological, social and spiritual impact of COVID-19 on the children that we care for and their families. And we have two briefing notes, one looking at the social impact and one looking at psychological and spiritual issues. And I've seen already in the comments section that there's been some comments about spiritual and spiritual care. So I'd like to ask our next speaker, who is Tracy Brand. She's a social worker and one of the directors of Umduduzi Hospice Care for Children in Durban, South Africa. And she's going to look at the psychological, spiritual and social impact of COVID-19. So over to you, Tracy, and thank you.
Thank you, Julia, and thank you to the team who assisted in putting together these briefing notes. If you go to the next, you'll see that there are the two briefing notes. Sorry, my computer is not changing.
Okay,
Yeah, I'm going to continue while we wait. Yeah, there we go. So there are the two briefing notes, and thank you from all over for putting these suggestions and key facts together. If we look at the psychological, spiritual, and social impact of COVID, but just of isolation in general to children with palliative care needs, the impact is significant, and isolation is huge, and these measures are going to severely impact our most vulnerable, and of course those children living with palliative care illnesses are obviously incredibly vulnerable already. They have complex medical needs, and their fear and anxiety around the illness and the parents' fear and anxiety around the illness is going to get even more greater during this time because of the fear of what might happen should they get COVID or should a family member get COVID. There's also the uncertainty of what does this mean? You know, how many people are going to get infected? Family are going to get infected. We know that access to social media can be of great use to kids, especially to assist with the suffering, the social isolation. But many children, especially in our context, don't have access to social media, and therefore the isolation and the negative psychological effect of that is going to be greater. Social isolation is already high for children with palliative care needs. They don't often get to see friends, they don't often get to see family, and this is going to increase dramatically through this pandemic as isolation and physical distancing takes place. Next slide, please. So the key facts around psychological rather, is the physical distancing and the PPE. They're around all over the place, and the extended quarantine is going to have a negative psychological effect, many of which are going to be long lasting. And seeing people wearing PPE can be quite scary, especially for children, if they don't know the doctor already and the doctor's now coming towards them with all this gear on. That can be quite intimidating and can increase their stress levels. There's also the fear of infection themselves and dying, but especially for their loved ones, because as we've been saying, there isn't much related to children and infection, but the risk of caregivers is huge. And I think a lot of children who have had access to information about COVID have great fear that their caregivers might get infected and what that might mean. There's also the disruption in routines. Obviously, going to hospital for your regular visit isn't happening, and that can be lack of peer support. A lot of our older children look forward to going to their clinic visit because they get to see people like themselves, because they don't get to go to school necessarily. So that disruption in routine, that lack of peer support is going to have a huge impact on our children. Linked to that is community profile. Many of the children all over the world, and again, I'm speaking specifically of my context, they come from low income, rural settings. They have lack of access to sanitation, to clean water, to basic needs, basic rights, basic services. And they're also child-headed households. And this is going to increase the stress, which is going to increase attachment to their caregivers, and that's going to increase stress in adults. We've also noticed that knowledge gaps between parents and children sometimes promotes irritability and anger. I know my teenage children get very frustrated with me when I try to act like I know what's going on. So if you add the isolation and you add people stuck together in one place, the knowledge gaps, a child with palliative care needs needing more attention, irritability and anger are potentially going to increase. Next slide. Okay. There's a change now. Children with palliative care needs, as I said, are already isolated, and this is compounded. The isolation also leads to lack of support. Families often rely on friends, rely on extended family, rely on the healthcare system and the social system to provide extra support for them in caring for these children with palliative care needs. And with the isolation, this is now not a possibility. And families are going to be left struggling at home to try and care for their children. The financial strain already exists, and this is going to be exacerbated during lockdown. For us as South Africans, we've only just entered level, what they're referring to as level 4. But prior to that, unless you were an essential service, nobody was allowed to work. And a lot of families rely on piece jobs to get income to feed their families. If you have a child with palliative care needs, there's a good chance that they have special needs in terms of diet and stuff, and money is not available. What we've also found is children in hospital, with the isolation, a lot of them are alone and therefore have nobody caring for them. because the family aren't allowed in and out of the hospital. But in addition to that, the fact that the family are not working, they don't have the money and the means to get to the hospital to visit the child. And that isolation is even more exacerbated then, because the child isn't just isolated, but they're alone. There's also a lot of uncertainty regarding the lifting of the restrictions, and social distancing is still going to be up for about another 6 to 9 months. And this is going to result potentially in children and their families living with fear and anxiety for an indefinite period. And again, with children with palliative care needs, getting them to hospital, that fear and anxiety of getting them on public transport or on hospital transport to get to their appointments is going to be increased because of the fear of infection. End-of-life care or advanced care plans potentially might not be finalized because the child wasn't at that point when we last saw them, and may deteriorate during the time of isolation, and they may not be able to get to us, and we may not be able to get to them. So trying to find a unique way now of managing end of life and the advanced care plan is going to be important. But what also may happen is that those are in place, but they're not able to be fulfilled because of the isolation, the social distancing, perhaps where the child wanted to be or who they wanted to be with them during this time. The increase in social media coverage is increasing in stress, and I'm trying to avoid as much as possible because it can be quite overwhelming. And one of the things that we're particularly concerned about is the increase in verbal and physical abuse in homes. Lack of movement can result in already existing abuse being worse. Frustration at not being able to help your child is potentially going to lead to an abuse or physical abuse situation, either towards the child or towards the caregiver. Next slide, please. So what are some of the recommendations? I think when we're working with children, it goes without saying, we have to consider their age and their cognitive development. And what is important is that we need to acknowledge and normalize their anxiety and their fears and any other emotions that may be forward. And I think that's where our spirituality comes in as well. A lot of children have been isolated from their spiritual homes because of COVID and the social isolation. They're not having access to the care that they would normally have got. So emotions are going to be even higher. And when discussing with children, we need to look at where they are age-wise and cognitively. And we need to then empower them through age-appropriate information. And we can utilize social media and other telecommunication where possible, but obviously not everybody has access to that, and that becomes quite difficult. And also if there's language barriers, the use of social media and telecommunication is not possible. There are resources such as My Hero Is You, how kids can fight COVID-19, and that's available in over 30 languages. And it's important for us to empower parents and caregivers to be calm. That is, I know we're all scared and everybody's worried about what's going on, but we need to try and remain calm to help our kids through this time. We also could create a COVID time capsule with some of our children, and these can be shared with their doctors, with their school friends, when social restrictions are lifted. Also drawing, art, the normal things that we would work with kids with to share their emotions would be important at this time, especially as they're feeling more and more vulnerable. Encouraging the positive expression of feelings is very vital, and we can use many different ways of many different forms of getting that information. Next slide, please. So engage in creative activities. Honesty, preparedness, and recognition of death is vital at this time. People know that it's happening, and we need to be as honest with them and prepare them that their caregiver may die, they themselves may die because of an underlying illness, and if they get infected. we've got to explore creative ways to approach PPE. I know there are some doctors around the world who are putting photos of themselves on the front of their PPE so that the children get to see what they look like, and then they can create a picture of them in their minds as they are working with them. Seeking information from trusted sources is very important. There's so much fake news and so much weird and wonderful stuff going on that we've got to ensure that we're giving the right information to our parents and to our children. Encouraging children's expression of spirituality through a search of meaning and purpose, and through connectedness to themselves, to others, to nature, or to a higher being is very important at this time. Most of our children with palliative care needs have often had many spiritual questions, many questions as to why them. And I think at this time when the situation is even more extreme, those expressions are going to get more. Our older kids are going to look for purpose behind everything that is happening. And we should allow ways of spiritual expression, either through poetry, storytelling, music. We have to build the child's self-confidence in sharing what they're feeling in terms of their spirituality. We need to manage searching questions when a child is dying or when a caregiver is dying with truthfulness and with compassion. We got to support the family throughout the illness and bereavement, and this has to be obviously done with compassion. And we need to train healthcare workers in communication skills that we commonly use in palliative care, so that they're able to provide better support for the family. Next slide, please. As said previously, we need to avoid separating children from caregivers where possible. Unfortunately, in our setting, that isn't possible because families are being asked to stay at home to ensure that hospitals aren't infected. So we need to then ensure that care is received somehow. And that may be from a nurse that the child really likes if the child is hospitalized, just to create some familiarity and helping them deal with the fact that their caregiver is not with them. Where possible, we need to try and provide regular contact with the caregiver through a scheduled phone call or through social media where available. And we need to look at encouraging and innovative ways for family and friends to continue communicating with children during this time. Any concerns that a child raises about their own illness or about COVID, we need to obviously address in an age-appropriate way. And we need to encourage discussion about COVID so that we're ensuring that our children have the correct information. If possible, limit their exposure to social media because this will help with reducing stress. And establish new routines if this is appropriate to help children feel secure, and providing time for them to express themselves during play. Ensure that helpline numbers are available for both physical, verbal, and substance abuse. Next slide, please. I think some of the key messages that we need to be telling children and children with palliative care needs is that the adults in your life are doing their best to keep you safe. And as children, they can empower themselves by asking questions, by staying at home, by washing their hands. And I think what's important for all of us is to share the positive stories about COVID-19, not just all the negative stats. And I hope one day, if you go to the next slide, I'm looking forward to when we go from this to this. Thank you very much for your time.
Thank you very much, Tracy. And this is one of the big ongoing challenges, I think, from the COVID-19 pandemic for both adults and children, is this ongoing impact of isolation, of not being able to be with loved ones in a hospital, the impact of what is happening at the moment. And we're just beginning, I think, to hit the surface of that. And this is certainly going to be something that is with us for a long time. And one of the areas that we haven't talked about today, but I think we'll hear from Stephen later, we might be looking at later, is the whole issue as well around grief and bereavement and the impact of that. And a lot of what we're talking about, although we've been talking about the impacts, the psychological, social and spiritual impact on children with palliative care needs, many of this is going to impact children generally. And so there's going to be, I think, lots for us to learn as we come over the following weeks, months, and probably years. So thank you very much again, Tracy. And now I'd like to ask Sharon Thompson to give us a few reflections. So Sharon is a mother with lived experience of palliative care from Ireland, and she was part of the review team who reviewed our briefing notes. So Sharon, we're really pleased that you could join us, and I'd like to hand over to you.
Thank you, Julia, and Claire Morris and Stephen and anyone else who invited me to reflect on the speakers today. I've just made a few notes so that I will keep to the time and be brief. I'm interested in rare disease and children's palliative care following our own experience in accessing care options for our only daughter, Victoria, who died in Ireland's only children's hospice in 2012. So since then, I've been very active in trying to support other parents and to advance children's palliative care in Ireland and elsewhere. It was my involvement with a special group of mothers called our Extra Special Kids in Ireland that prompted this series of webinars. And we are a group of over 200 mothers, and we're delighted to see professionals being heard by each other globally. We're delighted that our asks were answered in that regard. However, I can see that there's a definite drought in the parent or the patient voice in these webinars, as much as we're delighted that they're going ahead. But I was delighted as well to see today that the speakers commented on a lot of things that were on my list. So thank you very much, speakers. You did a wonderful job today. Thank you, Tracy, Anna, and Sat. I was delighted again. I'm very delighted all the time, but I'm delighted to see that you mentioned that parents should be encouraged to be allowed to stay with their children for obvious reasons. I think that the word should be must, if it's at all possible, that parents can stay with their child. Parents are experts of their own child's condition. Healthcare professionals might not like that term, but they're experts for their own child, and it would be excellent if they could possibly stay with their child on the care journey. It would be very much appreciated. Advanced care plans are causing a great deal of worry. Whether these are in place or they're not, it is felt that these are not being used correctly, and communication really needs sorted around advanced care planning within the palliative care community. Parents need reassured that these will be used in the child's best interests and that they are ethically sound. Communication in general in Ireland, where I'm based, is going quite well. But there is no one answering specific questions for Life Limited or children's palliative care or the children's palliative care community. We're probing for simple answers, and this is causing a great deal of anxiety. We understand that the answers are few, but we would really like for there to be better communication, strategies put in place. Parents cannot read reams of documents or guidelines, and they definitely couldn't write lots of briefings for things like today. So I was delighted to hear Tracy mention a helpline. That would be very, very appreciated, and I'm sure it could be something that other countries could take on board. PPE was mentioned, and I'm very conscious in Ireland that we have many unpaid home carers who are not considered to be key workers. This needs to be addressed in general, but there should be perhaps emergency packs of PPE given to home carers going forward. They would be well fit to use these at the appropriate time, so perhaps emergency packs might be considered. Appointing and preparing substitute cover for primary carers, I was glad to see that mentioned as well. Families though need professional help to roll in behind them at times of crisis. So there should be government or charity assistance and support for the primary caregiver if they become unwell. Expecting families to organise this themselves is really not possible. These children have complex needs, and professional medical care should come in behind them, and it should be pre-arranged support for these exceptional circumstances. And just one last point, the symptom control issues that were mentioned are massive. Irish parents are lucky in that they can possibly ring their healthcare providers, but they are still dealing with existing and new symptoms at home alone, and they don't want to overburden systems. So there needs to be consideration of these vulnerable communities in the reversal of the COVID restrictions. When will services, respite, surgery, consultations, and all of those resume? And I know that each country will be different, but this should be communicated effectively with the palliative care communities in the respective countries. So I was really glad to hear that the psychological aspects of the virus were understood by the speakers today. I was glad to hear that they understood that it was a new layer of awful for families. Parents and patients are living in lockdown with the life and death situation daily. So this is their world for years. Hence, parents and patients need to really be meaningfully involved and listened to at times like this. There are articulate, passionate, medically aware patient and parent advocates, ready, willing, and able to join in your global palliative care movement, but they really need to be asked and supported when they want to be involved, or they need to be asked to be involved and brought to the table. And perhaps this is a very opportune time with COVID. This is the time to make that happen. Thank you very much, and thank you to all the speakers today. Thank you.
Thank you very much, Sharon, and thank you very much for so eloquently advocating for the needs and the views and of parents and children. And I think one of the challenges for many of us, I know for me originally, was I was being asked questions that we have no answers for. And I think as this pandemic goes on, we're beginning to find some of those answers. And as Sharon says, it's so important that we can communicate with the children and the families with palliative care needs so that we can provide them with as much support as possible. So thank you all very much. We have about half an hour left for questions and answers. And we have an extended panel. So I'd just like to welcome to our panel as well. We have Lizzie Chambers from Together for Short Lives. We also have Dr. Ruti Kiman, who's a pediatric palliative care specialist from Argentina. And I think we also have Joan Marston is on the team as well. And of course, Stephen and myself. So I'm going to hand over to Kate and Shelley, who have been looking at your questions. And please do add in questions to the chat. So Kate or Shelley.
Thank you very much, Julia. It's Kate here. Thank you to all the presenters for these really excellent presentations. So I'm just going to be asking the questions that have come in through the chat. There are some that I saw were answered in the chat box, but I'll just repeat those. So if the presenters just bear with me, it's so that all the attendees can hear and not just the panelists and the people involved. So the first question is clinical in nature, just asking, can you talk more about the infection risk to healthcare professionals with buccal use of medications?
If you are just using the buccal root per se, then you're just taking a syringe and putting it in the mouth. That's not that different from putting a medicine in the mouth. You're not actually generating aerosol. So a child will spit out medicine it doesn't like, whether you're giving it orally or whether you're using it buccally. The reason for trying to recommend the buccal root is to try and avoid people using needles in the children, trying to sort of avoid that contact with the mouth. But at the end of the day, we've got to feed these children. We've still got to give medications to our children. So using a buccal, it doesn't carry any more or less risk than all these other things.
Thank you very much. Was there another presenter who wanted to add to this? Then I'll just go on to the next one. The question was that the attendee was not aware of evidence that morphine is not absorbed buccally. And Sat, if you could just repeat the reference that you quoted in the chat box.
Okay, so the reference is the use of buccal morphine in the management of pain in children with life-limiting conditions. And it was by Renee McLaughlin from Great Ormond Street, and that was 2018. And she did a very, very thorough study based on peak cheek models, which is actually how you should be researching through with buccal medication. And she managed to show quite convincingly that the absorption that people have been seeing is not through the buccal route, but it's actually just gastrointestinal further down. There are implications to that. But if you don't use morphine that way, if you do, your pharmacokinetics and dynamics are all going to be messed up.
Thank you very much. Then the other question, so you can hear my own child in the background. The other question was, why is codeine contraindicated for cough in COVID patients?
Okay, so codeine itself is what we call a prodrug. And a prodrug is an inactive drug which has to be activated by the liver. The enzyme within the liver, the cytochrome that actually activates it, is very variable, particularly in children. And the younger the child, the less likely they are to have an even level of that particular drug. Now, most children don't have enough, but there are some children that hypermetabolize this. So there was a big issue in the early part of the last decade where children were dying when they were given codeine because they hypermetabolized this. We normally metabolize 10% of codeine that you receive into your body. These children were overdosing and were requiring naloxone to reverse the effects. Now, codeine, when it's actually absorbed into your body and it's converted, it's actually converted to its base compound, the effective compound, which actually is morphine. So in 2012, WHO recommended that codeine should be stopped for children, and that if you need to give a medication for that weak opioid level, you give lower dosages of morphine. At the end of the day, morphine absorption follows a very good, clear pattern, has a high level of absorption. So why use a drug where you don't know what's going to happen with it? So although there are cough linctuses out there, Folcodine, which contain codeine, and adults use these all the time, in children, I would recommend that you just use a low dose morphine compound.
Thank you very much. So we're just going to open this up to the extended panel and ask, what is the place of spirituality and what are ways to include spirituality in pediatric end-of-life care situations?
Who would like to answer that one?
Joan, do you want to take it?
Okay, I can take that one, yes. I think it's very important that we understand what spirituality is. And it's about meaning and purpose and about connectedness. And so what gives a child's life meaning? It depends on the age of the child. So each child is unique. If it's a baby, the meaning is in being loved and being comforted. If it's an older child, they'll want to ask questions. Meaning might be in the feedback that we give them that builds their self-esteem. And the connectedness is the connectedness to themselves. How do they see themselves? How do we build that self-image of the child? The connectedness to others, which can be very difficult in this COVID-19 time, except if you have social media. And so it's building up those channels of connectedness. Their connectedness to nature is getting them outside, getting them connected to the natural world. And then, of course, their connectedness to a higher power, a spiritual power. They might belong to a religious community. in which case the rituals of that religious community will help them develop their spirituality and their connectedness to God. And so there's so much that one can say about it, but it's really about meaning and purpose, helping that child find meaning and purpose, and helping them to stay connected to what is important to them.
Thank you, Joan. Does anybody else want to comment on that? Kate, can
Sorry, Julia. Just to add to what Joan was saying, you know, I think something that we often don't do when we're working with our children is to look at the spiritual component. And I think at this time, as we mentioned earlier, those needs are going to be even bigger. So to find a space to be creative, to ask children what they think this is all about and how we can help meet those needs would be really, really relevant.
And Kate, if you don't mind me coming in here, there's a interesting comment in the chat box from Rosa saying the most common words during this presentation have been, we've talked about isolation, anxiety, fears, but also hope. And I think that links very much into the whole issue around psychologicals and spirituality. So Rosa's asking, what would be the main advice that you would give to parents and families? And I'm interested to hear that from a couple of different perspectives. So Ruti, from your experience in Argentina, what advice are you giving to parents and their families at this difficult time?
I think many of the issues have been covered by the presentations. And I think the most important thing is to know and respect and have an individualized view of the family, because each child and each family had their own beliefs. And I feel that perhaps sometimes we generalize, and this is something that we have to take into account. So first of all, I feel that one thing is that perhaps the professionals have to have a most proactive view. And for example, in Argentina, the committee of the Argentine Society of Pediatrics had made some recommendations trying to have a proactive access to the families, taking into account two things. If the child is stable or unstable, and the complexity. And in this way, perhaps call the family and see what are their needs. And I feel sometimes we let the family call us, and perhaps we have to change and plan about which patients and which family have more needs. And of course, have an holistic approach on this that has psychosocial issues and also spirituality. But if you have symptom management and emotional management, I feel that spirituality is also going to take into account.
Thank you. And Anna, you work in oncology, and we know within oncology that parents will have had anxieties and fears when their child is diagnosed with cancer, then hope, and then this comes along, and those emotions are all up in the air again. So what would your main advice be?
Well, I was just taking some notes not to forget anything. Well, the main advice we've been giving to our oncology patients are two sides. First of all, stay safe. And is everyone hearing a noise?
Yeah, so
Yes?
maybe somebody's put something that is gone.
Okay.
I think somebody put something on their keyboard.
I don't know. Oh, yeah, it was my keyboard. Sorry. So sorry, because I have an iPad and I just put it on top of the keyboard. Sorry about that. So what are we telling patients? First of all, stay safe. Families, stay safe. it's not only the child that has cancer and is immunocompromised and is at increased risk, but the family, especially the main carer, is also at increased risk. So everyone stay safe. Don't take risks. As Seth also said, don't be heroes, but don't take risks. And second, we've been telling them to stay connected. Please do stay connected, even though we are trying as much as possible to avoid non-essential visits and non-essential interventions. We tell people to stay connected. Call us if there is any problem, if there is any change, if there's anything you need. I'm sure other countries are seeing what we are seeing in Portugal, which is in adults an excess mortality. So the feeling is that many people are staying home because they are afraid of going to hospitals especially, and so they are dying at home, eventually from preventable causes. So we are telling patients, don't stay home, call us. If needed, you can come, because we have separate circuits for COVID and non-COVID patients. And I'm sure in many, many countries and many institutions, this is true as well. And also let us know your difficulties. And I think Tracy mentioned many people lost their jobs or have decreased income. So people have even more difficulties buying medicines, buying food, buying supplies. So we have to acknowledge that and be even more there for the people. So the social workers are really having a very difficult time here, trying to help all these families with all the needs. But we tell patients, we tell families that so far there have not been any deaths from COVID-19 in children with the cancer. So hopefully we will be able to get through this safely.
Thank you. And before I hand back to Kate, Lizzie, just interested, because obviously Together for Short Lives, you work very closely with families as well as with health professionals. So I just wondered your thoughts on this.
Yeah, I mean, I think very similar to the points that Anna has made, really. I think a lot of the work we've been doing over the last 2 or 3 months is really helping families connect with each other. So I think the advice would be, use charities and organisations that run things like Facebook groups or ways to talk to other families, because it is very, very isolating for families who are, at home shielding children. Mm-hmm. Now that we're sort of, 7, 8 weeks in, I think the strain's starting to tell. We're certainly sensing that families are sort of needing to have short breaks, just because they are exhausted from providing all that care 24/7. So it's kind of, reach out to professionals and get that help if you need it. And I think echoing Anna's point, really, that, do go to hospital, do call your professional team if you are worried about your child. Trust your instincts as the main carer, that child. Mm-hmm. Don't avoid going into hospital, because I think that is more of a risk than COVID-19 for these children.
Yeah, and I think, and maybe Sharon, I'll just come to you briefly, this whole issue of connectedness to me is coming out. Connectedness for us as health professionals, learning from each other, connectedness between the health professionals and social care professionals and the parents and families, but also connectedness between the families. And I think, Sharon, you were saying you're doing some webinars for families. Don't know if you just want to share a bit about that.
Yes, we just started connective webinars like this for families, so that we can see each other face to face, and that there is somewhere for us to go. One of the things there that came up was that the whole idea of the communication, though, between when you do get answers for families. We understand we're used to having no answers, especially in the rare disease community and with palliative needs. Parents understand that answers are very few, so we're used to that. But like, for instance, the whole idea that children were least affected, and that hospitals weren't overwhelmed in Ireland, alleviated a lot of fears. So if those two simple things were communicated effectively to parents as soon as it became, apparent, then that would have helped a great deal. So it's even just simple communication and simple videos, the general briefings that they do in some countries with the government come out and they answer a couple of questions. And I think even if the palliative care community had that patients and parents could come on and ask questions, even if the questions are, we don't know, or the answers are, we don't know, we're used to that. But they would feel that there was somebody out there cared. And I know that you all think that you all are working really hard to communicate with your patients. But for parents around the world, I'm sure that they do not want to always have to be the ones that ask. And it's the quiet ones, and it's the ones that are suffering probably the most that say I'm fine, or don't communicate. So I think it's important that you go to them.
And that fits in with what Ruti was saying about us being proactive.
Yeah. Parents will support each other. They will, and they do. They do if they've access to the.
Yeah. So communication is key. Thank you. Back to you, Kate.
Everyone, the next question is for Sharon again. How can we better ensure that the voices of people directly affected by palliative care needs are heard by decision makers as we face COVID-19?
Ooh, that's a difficult one. I think that, can you all hear me? Sorry if I unmuted myself. I think this is about building up trust and general listening. I think that if there was, that I hope that what you might do is that the professionals might come on to my webinar with parents, and that you would listen and build up a trust. I think that the whole inclusion of us has to be made as easy as possible. Like, for instance, today, to join in the webinar, you had to provide briefing notes, which I totally understand. But a parent with a sick child isn't going to have the time or the energy to partake. So it's making it as easy and as accessible as possible. I want to keep my answers brief. So.
Thank you.
Thanks very much, Sharon. The next question is for the whole panel, asking how can the psychological signs of fear and stress in children be managed?
Who would like to look at that one first?
I'll tackle it first, if that's okay.
Yeah.
Sorry, my dogs decided to bark at that moment. I think one of the most important things is acknowledging that those the fear and the psychological stress is present, and to try and help the children, obviously given their age, to identify what they are feeling, and to try and identify the source of that feeling. And this can be done through many different creative ways. I find that playing with kids or drawing with them can often bring a lot of that stuff out. I think one of the key things, though, is to draw with the child and not for the child. I think sometimes as adults, kids are playing and we come and join the game and take over because we have something that we want them to talk to us about. So we try and lead the conversation that way. I think what I found more successful is that you come and just sit next to the child and start your own game or start doing your own drawing. And then the kid pretty soon wants to see what you're doing. And then you get to maybe start your.
Have we lost you, Tracy? Tracy, you're on mute.
Mute? There
yeah, you went.
No, somebody muted me. I think the most important thing, and I'm repeating myself, is just to acknowledge that those things are there. And I think what we often want to do is just find another way to deal with it. And sometimes we want to just medicate, but let's find out why the child is experiencing that, help them identify the emotion, help them name the emotion, and normalize it. say to them, it's actually okay to be feeling that in this situation, and then look at finding a creative way together of looking at that further and taking it further, and together finding ways that might help the child feel better.
May I, Julia?
Yeah.
I would like to add that sometimes we know what's happening with the child because parents are telling us. And I think sometimes the needs of parents are not the needs of the child. So we need to go to the child, play and be with him and know what's happening. Because sometimes this is really very important. Parents are stressed and have their own needs, and sometimes the child will tell us different things.
Yes, so important, and it keeps coming back, doesn't it, to communication. Communicating with the children, communicating with the families, communicating with each other, learning from each other, and yeah, communication is so key. And I think that's one of the things within pediatric palliative care, we try and we work hard at our communication. So we need to bring that those communication skills to make sure that we are communicating effectively and communicating more. Kate, back to you for more questions.
Thank you, Julia. A question has just come in for Sharon, just asking how can families connect to your webinars?
Oh gosh, I will share the link with Julia and other organisations. Literally, we've only started them, but we would like and we would enjoy having other parents from around the world. Of course, at the moment it's just Irish based because we wanted to perhaps facilitate talk within our own country. But if other people would like to join, that would be great. I know that hopefully, I'm going to put you on the spot now, WHPCA, but hopefully there will be a patient and parent one in the planning,
yeah,
which would be an international one. And we would love for parents and patients to be involved in that.
There is definitely going to be one. I can't remember the date offhand, but it's planned in the scheme.
But I can, as we go on and hopefully have success with ours, I would love for others to join. I'd love it to be an open space and others could come along as well. Does that help? Thanks,
Sharon. Yeah.
Can I come in quickly?
Yep.
Lizzie, I was going to say we're actually planning a special webinar session where we've collated lots of questions from parents on our Facebook group. So we've got lots of those really tricky questions, and we've got parents who are going to interview doctors on this webinar and ask for some of these tricky questions.
Mm-hmm.
So we're recording that so we can share that with your international audiences as well.
That would be good. So we could put a link to that up on the global palliativecare.org website and on ICPCN website, so that we can try and help bring those connections together. Thanks, Lizzie.
Thanks, Lizzie.
Kate.
Thank you. There's a question that came in. I think it was Tracy who mentioned that there's been an upsurge in cases of physical abuse during lockdown. So the question is twofold. It's, as a palliative medicine professional, do you think you have been trained to talk about abuse of a physical or a sexual nature? And what legal aspects would you need to keep in mind? Do you think the law would protect a medical professional if you were to wade into this territory?
Sure. A difficult question. I think if you look just straight at palliative care training outside of our respective disciplines, there's nothing that really looks at abuse. I think if I look at my training as a social worker, that was stuff that we learned to deal with, and my years in child welfare obviously was something that we learned to deal with as well. I think what is important is within your respective countries to know what the laws are, especially related to children, violence against children, but obviously know what the law is, what can protect the person who is being abused legally, how you can access that. Are there places available that you can take the parent and the child to? I know within our legal setting, the Children's Act, the Children's Act states that if we suspect abuse or if somebody has told us there's abuse and we do nothing about it, the professional is liable for litigation against them. So I think what is really important is to know what is available, what your law states. If you suspect that something is happening and you have a good enough relationship with the person who you think is being abused, try and find a way to have a conversation with them away from the abuser, but given the fact that we are in isolation, that is not always an option. And what we've noticed is that, cell phone conversations either through WhatsApp or through short messages often get taken away by the abuser, and therefore anything that you've planned can lead to further abuse to that particular person. So from my side, it wouldn't be to try and get involved unless you feel that you have the skills. It would be to know exactly what you can do legally to protect that person and put those steps in place.
Thanks, Tracy. Kate, I think we have time for one more question.
So can I ask a question of Anna? Can you share some advice on how you would discuss advance directives with the family of a child with a life-limiting illness, especially in this context of COVID?
Well, I think it's been addressed before that one of the problems in the context of the COVID-19 pandemic is that maybe we will not be able to fulfill some of the wishes that may be stated in an advance directive, especially regarding place of death and the presence of loved ones. So it might be even trickier than usual, because we have other limitations in place. And I was hearing this discussion and looking at some of the questions in the chat, and I think it's the reality across the world seems to me to be very different, because it seems that there are some countries where children are really being left alone, separated from their carers, right? Is that true?
Yeah.
And children are dying alone. So it's really saddening for all of us, I think, that if a child is approaching her last days of life, and she has to be alone because of COVID-19, that's really, really very sad. I think most countries will have a solution in place, like we have in Portugal, that one carer is allowed, even if that carer has to also be tested for COVID-19 and to be negative, of course. But it's really, I understand that some countries don't have this possibility, and they have to restrict. So coming back to your question, how to address this, I think we have to thread with even softer steps this issue of advanced directives. But as always, we have to prepare for both scenarios, for a scenario of impending death and for a scenario of everything going as best as possible and the child going back home or staying home or recovering or whatever it is. And I will take the opportunity to also address a question which was one of the first questions in the chat, which was about telemedicine, virtual health, and the likes. And I would like to say that there's been a lot of talk in oncology about this. And people are asking themselves, is this going to become the new normal? You know, virtual everything. And I think, as always, the answer is going to be somewhere in between. This has forced us to move maybe faster than expected into this new reality of Zooms and webinars and telemedicine and everything. But as I said before, this is easier if you already know the patient, you know the family, and it's just like a touch point, you know, just talking about an issue that is already known and that you have already discussed in person. Because some issues like the Advanced Care Directive are probably too delicate to be addressed for the first time in a virtual consultation. It should probably best be addressed in person. But of course we have to adapt, and we have to take advantage of what we have. But yes, this is a new reality, and we will have to try to extract the best experiences from it, and when this all passes, go back to person-to-person contact as much as possible. This is my belief.
Thanks, Anna. Now, before I close, I'd just like to ask Dr. Stephen Connor from the Worldwide Hospice and Palliative Care Alliance to tell us about next week's webinar. So, Stephen.
Thanks very much, Julia, and thanks to all the presenters today. This time next week on Friday, we will be having a program that will be focusing on two of the briefing notes. One is the suffering of isolated patients and families, the psychological and social implications of physical isolation for patients and families during the coronavirus pandemic. And the second briefing note will be on grief and bereavement for family members who can't visit their sick relatives or attend funeral services. We're going to be having speakers from Canada, from India, from Zimbabwe, and the United States. So we look forward to welcoming you back next time. And for future reference, we have 7 more presentations in the queue that are being developed. But we're going to, after next week's presentation, shift to Thursdays because we have a lot of the world that observes religious functions in the Muslim faith on Friday.
Thank you, Stephen. So I'd like to thank everyone for joining us today. Please do join us for future webinars. And I'd like to thank all of our panelists today for their input and for their presentations, and also to thank each one of you for your input and for working with us on this project and on these briefing notes. I found it very stimulating working with you all. And I think for me, the whole area of communication is key, the new reality, what we learn from each other and how we learn and how we make sure that the voice of the children and the parents is heard and that we are listening to what is being said, and how, as we find answers to questions, we share those answers. So I'd like to thank everyone, and on behalf of the Global Palliative Care Organisations, I'd like to thank all of you for being part of our discussion today, for all that you are doing within palliative care, and in particular at this time of the COVID-19 pandemic. So please stay well and keep safe, and we look forward to seeing you next Friday. Thank you and goodbye.
Thank you. Bye.